Hello. Hi, everyone. Thank you so much to all of those who are tuning into our next ECG lesson. And for those who are live, you can ask questions as normal. My apologies, the last 2 weeks we didn't have any as I was on leave. Then I had to build up some material again. So hopefully we'll be able to learn some stuff today. So for those of you on the WhatsApp and Telegram groups, you would have seen the ECG being posted. And again, my apologies for changing the times. It's just a bit more convenient at this time. But in any case, even I'm sure you can catch up with the lessons on YouTube if you need to. So let's get into it. So what we have here is a 33-year-old obese man with sharp chest pain and dyspnea. So as we know, patients with a high BMI are more prone to having cardiac events. It depends on their mobility. It depends on their cholesterol levels. There's so much that does predispose them, unfortunately, towards cardiac events. There's a big genetic component to it too, as we've learned in recent years. In terms of cholesterol and atherosclerosis, and that also has a big genetic component. And generally, if the person has the unfortunate combination of high BMI and genetic predisposition, they can often present with infarcts or cardiac abnormalities at a much earlier age. So if you were to get a patient such as this now with sharp pain and dyspnea. So dyspnea is not generally associated with an infarct unless there's acute heart failure as well. So this would be something that you would need to correlate clinically. So I'm sure before you do your ECG, you would actually examine the patient. If you hear your basal crepitations, then you could assume that it could be due to an infarction. If the patient doesn't have those, then you have to think of other possibilities as well. Sharp chest pain does happen with infarction, but we must remember it's more common to have a crushing chest pain as compared to a sharp chest pain. So this description of a sharp stabbing pain brings in other possibilities such as pericarditis, pleuritis, pulmonary embolism. Direct trauma, things like that. So there's quite a few things, aortic dissection, so there's quite a few things that you have to think about besides infarction, especially when a patient has sharp pain. So let's go through our ECG here, and just want to annotate it a little bit, just want to see if I've got my line set up here. All right. So let's first look at our axis. So as we know, here we have lead one, and here we have lead AVF. And remember, as I always say, you can use whatever method you want. I'm just using this particular method, and then let's just plot out our lead one. So as we can see, our lead one is biphasic. But if you really had to look at it, it looks almost as though it's much bigger towards the negative side. So this means it's likely going either into the extreme right axis or the right axis. Those are two of the possibilities. And if we look at our AVF, we can see it's positive. So that means we're either going to have a normal axis or we're going to have a right axis. So in this case, we've got a right axis deviation that we can see over there. Okay. So that's the first thing that we needed to take note of. Now, let's have a look at the rhythm strip just so that we can see what's going on. So what we've got here, let's have a look at our P waves. So if we look purely at morphology, these are quite tall peaked T waves, all right? Now, you must remember the first half of your T wave represents normally your left atrial depolarization, contraction, sorry, depolarization, and the second half generally represents the right. I think I'm remembering that correctly, or is it the other way around? Okay, I stand to be corrected on that. I just was going to check it out. But in any case, so each one tells you a bit about both atriums. And once you have this particular pattern, these tall, upright P waves, this is something that we call P pulmonale. All right. So what happens with P pulmonale? It's basically telling you that there is a bit of strain on the atrium, specifically on the right atrium, and that can definitely lead you down the road of thinking that this could be something to do with the right atrium, right ventricle, and there may be something that's going on over there. If we look at our PR distance, we see that we've got 1, 2, 3, 4. So just above 4, so it's kind of borderline. But you know, you wouldn't call it an prolonged PR interval. Our QRS complexes are quite narrow, and after every after every P wave, we do have a QRS complex, and they're relatively regular. So except for this P pulmonale, the rhythm strip actually looks quite okay. If we look at the heart rate itself, let's just work that out. So it's 1, 2, 3, 3.5. So we're hitting about mm, 75 to 80 beats per minute if we look at this. So not necessarily a tachycardia or anything like that. Now let's look at each zone as we go through. So we'll start with the inferior zone. So with the inferior zone, you can see we've got leads 2, 3, and AVF. So in lead 2, you could argue that there's a very slight ST depression there. In lead 3, there doesn't seem to be any ST depression, but there is an inverted T wave. And we've got this little Q wave as well. And this, you know, coming again from the change in axis. So the change in axis with the right-sided axis again tells you that either something's happened on the left or that the right is consuming more um, is taking up more of the electrical current as compared to normal. And looking at the P wave, the P pulmonale, and the fact that you are getting a right-sided axis, it kind of leads toward right ventricular pathology, right atrial pathology. So you're thinking about something that's happening on the right-hand side. If we look at AVF, we can see again we've got these inverted T waves, which may be indicative of ischemia. Although right-sided ischemia wouldn't really fit with what we're seeing because then you would see, you know, should the right side be damaged, it's more likely that the left side would actually become, you know, dominant as compared to what we have here where the right side is dominant. Okay. If we look at leads 1 and AVL, which are your high lateral leads, we can even look at V5 and V6 as the lateral leads and the high lateral leads. But we'll just look at 1 and AVL for now, just to see what's going on. And the one thing you'll notice is these quite deep S waves in lead 1. They're also present there in AVL, but they're definitely present here in leads 1. So one of the features of pulmonary embolism that's often talked about is S1, QT, Q3, T3. So let's just put that one over here. S1, Q3, T3. All right. And basically what that means is that in lead 1, all right, sorry about that. In lead 1, um, you have sorry. You have a deep S wave, right? You have a deep S wave. And in lead 3, let's put it like this. In lead 3, you have a Q wave. And my typing skills are really terrible at the moment. And, 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 sorry about that. Somebody's just trying to call. and inverted T. So this is what S1Q3 T3 stands for. So in other words, in lead 1, which we can see here, we have a deep S wave. And in lead 3, we have a Q wave and an inverted T. So this is one of those things where I'll be honest, for myself personally, whenever I see a deep S wave, I always go and look for the Q3 T3 pattern as well, because that's quite indicative of a possible pulmonary embolism, even though it's only present in about 10 to 15 or 10 to 20%, I think they had mentioned, that actually present like that. But it is a finding that is seen. So it is something that you should try and keep in mind whenever you're having a look at an ECG. And it just takes you a little bit of time to come across and look at this. If we look at AVR in this case, there's no real ST elevations or depressions. And in all of these, we see these peaked P waves wherever they are. And the AVR here again, showing you that the right side is becoming a bit more dominant again. Once we come here into V1, you can see the slightly odd pattern that we have over here. Now, this may also be due to the the atrial enlargement, as we can see here. We've got this biphasic P wave, which again now is showing you that the atrium has shifted. The atrium is not in its normal place because it normally doesn't give you biphasic waves. It is a bit in depth, which I don't want to discuss with you guys and get you all confused. But basically, considering where V1 sits and where you get this biphasic wave, it essentially means that the axis of the atriums have changed. And the right atrium is actually pushing, rotating, and the right ventricle is actually rotating the heart, so because it's becoming right-sided dominant. So this is starting to look more and more like a pulmonary embolism. And as you can see here, we have an incomplete right bundle branch block. All right, that's what you see over there. So remember, a complete right bundle branch block is when the QRS complex is in this RSR or M pattern, but it's quite wide. And when it's narrow like this, we call it an incomplete block. We can see an inverted T wave. If we come to V2 and V3, we see ST depressions, which could, again, be pointing towards an infarct. And we see inverted T waves as well. When we come to V4, V5, and even V6, again, we can see slight ST depressions, and we can see inversion of the T waves. So if you were sitting in your practice, or you were sitting in your rooms, or you were sitting in your emergency department, and you had this patient here who's presenting with possible signs of pulmonary embolism and who's presenting with signs of possible infarction, because you can't make the distinction immediately. Even though ST depressions are seen in pulmonary embolism, it is one of the findings. It's not a definitive finding. Let's put it that way. So it may be there, it may be absent. T-wave inversions along your precordial leads are quite common in pulmonary embolism, but this could also be due to infarction. T-wave inversions are also quite common during infarction. So you're stuck with two, but at least you have an idea of where you should go forward from here. So considering the patient's presentation, sharp pain and dyspnea, you would first start with your cardiac enzymes. You would do a blood gas in this case to see how bad it is. And you would also do a D-dimer to figure out if there are, possible clots that may be there, And of course, D-dimer, it depends in what setting it's done. And remember, D-dimer is a confirmatory test. It's not a, how do I explain? The absence of D-dimers or negative D-dimer does not necessarily exclude an embolism in the system, and the presence of it doesn't necessarily say that it definitely is there. So D-dimer is one that if you have clinical suspicion, then you would go ahead and you would see, by doing your D-dimers. Now, the other thing that you would do in this case, besides all of this, is that you would probably do an ultrasound of the lower legs, and you would try to see if there's evidence of any deep vein thrombosis over there. Although emboli can come from anywhere, the most common would be in the lower limbs, So if the patient had evidence of a deep vein thrombosis or, things like that, and especially in a larger BMI patient with a larger habitus, it's very possible that they may have mobility problems and they may have developed clots and things like that. So you would wait then to see what you get back. So if your cardiac enzymes come back as high, but you find your D-dimers are not really elevated, you would probably treat this patient more as an acute NSTEMI and manage them along those lines, because we've only got ST depressions everywhere. And if your D-dimers came back positive and your TROP-Ts or your CKI, TROP-Is, TROP-Ts, your CK, MB, whatever it may be, maybe doesn't come back that high, you would start to suspect that this could possibly a pulmonary embolism. Now, the good part is that the treatment for both, in most of our cases, is thrombolysis. However, if you are working in a setting where there's a cath lab, of course, if this turns out to be a pulmonary embolism, then it's a bit of a ways to actually send the patient for PCI because they're not going to find anything. So this is the type of patient who would probably benefit also from a CT of the chest to try and see if there are emboli present in those vessels. Now, there are other things that could point towards or help you to decide whether this is pulmonary embolism or whether it's myocardial infarct, and that's based on the history of the patient, danger signs or risk factors for the patient as well. So, for example, if we knew for sure that this gentleman was immobile, you would start thinking more about a pulmonary embolism. If this patient has a history of hyperlipidemia, has had atherosclerotic disease, has been then you would start going towards infarction. But you would, in this case, check for both. You wouldn't just isolate yourself to one or the other. That's the good thing about medicine, is that you have differentials, so you would go from there. So let's have a look. So this is the answer to it. So we have a sinus rhythm with a rate of about 85 and a T-wave abnormality consistent of the anterior and inferior ischemia and a rightward axis, which is what we said. So the ECG is highly suggestive of acute pulmonary embolism. In this case, this patient did have an acute PE, and the ECG demonstrates the classical S1 Q3 T3 that I had mentioned to you guys as well. And like I said, it's 10 to 15% of the cases of pulmonary embolism. T-wave inversions are common in pulmonary embolism, and the combination of T-wave inversions that occur simultaneously in the inferior and anteroseptal leads should strongly prompt consideration of this diagnosis. So in other words, T-wave inversions here and T-wave inversions here, which is what we have. And in fact, that's more common to find than the S1Q3 T3. And when you see it, it often lets you know that this could well be a pulmonary embolism. Also, the fact that we have a right-sided axis, tends to push our thinking more towards pulmonary embolism. But you would, for example, do a chest X-ray as well. You would have this patient on oxygen. It's not that you must make the diagnosis from an ECG. That's not the point of it. The ECG is not a diagnostic tool. It's a tool to in this case, for pulmonary embolism, your ECG, it allows you to suspect a pulmonary embolism, but you can't definitively make a diagnosis without other investigations as well. I hope that makes sense. So a right-sided axis is often found on ECGs of patients with acute pulmonary embolism or chronic COPD, So it doesn't necessarily mean that you've got right-sided axis. It could be other things as well. But in this case, it definitely does seem like, it could be. So what are the signs on ECG that you would look for? As we had mentioned, the S1 Q3 T3 pattern, a right axis deviation, which is what we had, complete or incomplete right bundle block, which we had, T-wave inversion in the right precordial lead, so V1, V2, V3, sinus tachycardia, which we didn't have, ST segment depression in the right precordial leads, which we did have, but like I said, that's not pathognomic. You have to combine it with T-wave inversions in your inferior leads as well, atrial dysrhythmias, which we didn't have in this case, first degree AV block, which we were close to having but wasn't exactly there, the P pulmonale pattern, which we had, the QR pattern in V1, which we actually didn't see here because we had the block, and displacement of the transition zone to the left. So this has to do with how your R waves progress. So it's not something that we commonly discuss, so not to worry too much about that. And one of the other things that's maybe not mentioned here, but in terms of clinical science for pulmonary embolism is syncope as well, So, if your patient presents like this, plus a history of syncope, it's very, very possible that it could be a pulmonary embolism. Okay, so here we just look at what happens when you have an pulmonary embolism and your ECG is there. So remember, the sensitivity and specificity for ECG in P is low, but it leads to you suspecting it. So it's helpful in evaluating, and it's a supporting evidence for pulmonary embolism. Okay, along with your D-dimers, and CT chest, X-rays, these all have to be used in conjunction to be able to say, listen, this is or is not a pulmonary embolism. So what are the mechanism of changes that we have? So the first thing that you have is an increased adrenergic or adrenaline drive, right? So the sinus tachycardia is a common finding, but not present in every single patient. Does depend on previous cardiac disease. If there is pacemaker cell disease, there's quite a bit. And atrial arrhythmia, AFib, for example, but you may not necessarily see it, and it does confuse the picture when you do get it. So right atrial and right ventricular dilatation, which we could possibly see in our patient, incomplete or complete right bundle branch block, especially because of stretch, right axis deviation, and dominant R wave in V1, even though we didn't have that in our patient, and shift of the precordial transition point to V5 as the right ventricle rotates with dilation in relation to the ECG. So as this moves everything along, you start seeing that R wave starts changing as you are going over. But I haven't seen many instances of that, but I'll try and look up for one, and maybe I'll point it out on the group one of the days. And then you can have right ventricular ischemia or strain. So as we said, S1Q3, T3 is not a sensitive finding, but it points you in that direction. And T-wave inversion in the right precordial leads and inferior leads is very specific. To have them in either, it suggests it, but if you have it in both, it's actually a big sign that this could well be a pulmonary embolus. Non-specific ST changes, or ST and T-wave changes, which we had in this patient, and ST elevation in AVR or the right precordial leads, which we didn't really have in this patient. So if we had to go back to ours, we can see that we have got quite a few, we do have quite a few, sorry, I just want to get it right over there. So let's just see. So we've got here our S wave, S1. We've got our Q3, T3, as well as our T wave inversions, which you can see there. And we can see them here as well. So sorry, that didn't come out right. And we can see a right bundle branch block, which we have over there. And then as far as the transition point goes in this particular patient, it's a bit I'm just going to try and see where exactly that occurs, but you can see it starts occurring at around V5, where your R wave starts becoming smaller, but only at around V5. Okay, so that's one of the things that we can make out from there. So in this case, this patient highly suspicious of pulmonary embolism, and you would have investigated as such and hopefully reached the correct diagnosis, or at least pass the patient on with that differential, not purely as an infarct based on the ST depressions. Okay, so this is just a CT chest just to show you what the emboli can look like. So your pulmonary artery, your aorta, your cave vein, okay, and then I think they maybe the vena cava, I think. I'm not sure why they labeled it like that. But anyway, so your emboli, you can see them here, and this is a saddle embolus, all right? So it's sitting over two parts of the pulmonary. It could be one continuous one, actually. It just depends on the level here. So, these can be quite dangerous, of course, and often require early thrombolysis or early surgery in order for the patient to survive. So that's just a little joke to finish off. So I hope you guys understood the importance of looking for the signs of pulmonary embolism on ECG. And I must be honest, they over the last few years, like personally, I can recall many instances of seeing suspicious ECGs, working the patient up, and very often it does turn out to be pulmonary embolism, even without the X-rays, even without once the CT chest is done, of course, it confirms it, and then of course I can remember times as well we've missed it as well. So it just depends on how your patient presents, and you really have to keep an eye out for this. It's not just how to explain, of course every ECG is not going to be a pulmonary embolism, but if you look at the history that we got to this patient, which was of sharp pain and of dyspnea, you would start thinking possibly about that. And of course, if syncope is added onto that, then your mind really has to shift towards a pulmonary embolism, because that's really one of the cardinal clinical or findings on history, that the patient just suddenly fainted and recovered spontaneously, and then was okay after that. Well, not okay, but didn't have syncope again. So there's a few reasons for the syncope. There's vasovagal stimulation, decreased cerebral perfusion, decreased output from the left ventricle. There's quite a bit that's going on, because at the end of the day, what's happening is that you have this this right ventricle that's trying to push past this block that's somewhere over there. So it often ends up causing less blood coming back to the left ventricle, and that's what causes the syncope and decreased output, low BPs. There's quite a bit that can go on. And of course, your patients can go into acute right failure as well. So yeah, I hope everybody enjoyed that, and hopefully we'll have another one soon. And I just want to thank everybody. And yeah, let me just stop that there, and just thank everybody, and hope you learned a bit from it. Thank you so much. Keep well. Bye.